Hello, my name is Siddharth, and today I'm going to talk about ultrasound guided costoclavicular brachial plexus block. This is new approach of infraclavicular block actually, and this is targeting lateral, posterior, and medial cords of brachial plexus, and it is one of the approach of infraclavicular, and this is a new one, and targeted structure are cord. See, the costoclavicular region over here is targeted over here, and just below the clavicle, median to the coracoid process, and somewhere here the cords are targeted. So it is just like a supraclavicular block, but it is somewhat mirror image. See, supraclavicular block is approached just above to the clavicle, and this approach is utilizing just below to the clavicles at the level of subclavius muscles. See, so this is a specifically very good approach when you can't assess the supraclavicular fossa in many patients, like in COPD, which is very much depressed or the hollow like supraclavicular fossa. In that, the block can be little bit difficult, and in those patients actually these areas are not that much depressed, or when you cannot assess these area, you 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 can definitely go for a block over this area, and this is very little bit superficial to the infraclavicular, classical infraclavicular block, or like such that so because this is superficial in nature, the this block become little bit easier than the costoclavicular, than the infraclavicular block. Okay, so the targeted structure over here is that clavicle, below to that is a subclavius muscles, and here we'll find the three cords, and this is secondary. Okay, this is axillary artery, first part of the axillary artery, axillary vein, and somewhere here we'll find the serratus anterior muscle, and later on the lowest part is the pleura. So let's understand somewhere here also. This is clavicle, and below to the clavicle, on the lower side we'll find the subclavius muscles. This is pec major. So from here we are actually targeting the block. So the first muscle will be like pec major, second is the subclavius muscle, and then we'll find the three cords and axillary vessels, and this is the costoclavicular space. And below to that we'll find a thin layer of serratus anterior muscles, then it will be pleura and the lung. Okay, now let's try to understand what is costoclavicular space. So this is clavicle somewhere here, and this is a first rib. So in between the clavicle and first rib, we are actually targeting the cords or the brachial plexus, and so that the structure will be like the part of axillary, the first part of the axillary artery will be over here, axillary vein will be over here, and the three cords will be like that, will lie laterally to the axillary artery. So let's deal in this diagram. This is pec major, this is subclavius muscle, a layer, and we'll find the axillary artery, vein, and here will be the nerves. And nerves will be at this level will be most lateral will be the posterior cord, superficial will be the lateral cord, and posteriorly will be the medial cord. This is the serratus anterior muscle, and this is the secondary. So we are actually targeting in between this two area, clavicle and first rib, and this costoclavicular space is utilized for this block. Now indication are same as supraclavicular block, as because of it is one type of infraclavicular block, it gives superior analgesia compared to all other approaches and can be a site for continuous catheter, but it is little bit superficial to superficial in layer, but but because it crosses two muscles, it can be a site for continuous catheter. See, this is a dermatome, myotome, and osteotome of the costoclavicular block. Okay, now the limitation is that the coagulopathy, thick chest in large patients like vessel in the path, and the fourth one will be it is not going to block the suprascapular block as it does in supraclavicular approach of the brachial plexus block. So here the suprascapular nerve is not going to block. Okay, now scanning technique in that patient lies in supine. It's not necessary, but yes, with arm abduction, it causes improvement in the vision because you can very well visualize the costoclavicular space nicely when you abduct the arm, and the position of the probe will be just lateral to the clavicle or and parallel, inferior to the clavicle, parallel to the clavicle, and medial to the coracoid process. Uh, Generally, we utilize the high frequency linear probe. See, at this area, just inferior to the clavicle, parallel to the clavicle, and medial to the coracoid process. Somewhere here you will find the high frequency linear probe to scan the cords, and the layer will be somewhere like here. The pec major subclavius muscle will be the second muscle, and then we'll find the axillary artery pulsatile anechoid, and lateral to it will be the three cords. Three cords will be the first one lateral cord, median cord, and most lateral part is actually a posterior cord. Below to that you will find the serratus anterior layer, and somewhere here pleura and lung. So again one more picture: pec major subclavius muscles, axillary artery, somewhere here the bunch of the cords, serratus anterior, intercostal nerves or intercostal muscles, and then we'll find the pleura. So when we put high frequency linear probe over here, just below and parallel to the clavicle and medial to the coracoid process, we'll find this picture. This is pec major muscle, somewhere here, subclavius muscle, axillary artery looks like anechoid and pulsatile, somewhere here with the axillary vein. This is medial portion, this is lateral portion, and three cord will be lying over here in a particular sheath like pattern in a sheath. See, this is lateral cord, medial cord, and most lateral one is a posterior cord. Somewhere you'll find the serratus anterior muscles, intercostal muscles, and pleura. And this is second rib, this will be the first rib, and we are actually trying to go in between the two muscle layer just below the clavicle, and this is first rib, this is second rib. Okay, so let's see some color picture. This is pec major, subclavius muscle, axillary artery. This is medial, lateral, and posterior cord, serratus anterior, pleura, and thanks to Nizora for giving best pictures. See, the two approaches are there. That is, one is lateral to medial approach, inline lateral to medial approach. In that, the needle will pass will come from the lateral to medial, piercing the subclavius muscles, and the here will require dose is 20 ml for a adult. Okay. This is lateral to medial approach, means lateral approach, and one more is there, that is medial approach. In that, you are actually piercing the pec major muscle, subclavius muscle, and you are depositing drug somewhere here, because in many time in lateral approach there are some osseous calcification or the bony tissue, they actually of coracoid process, they may interfere while you're needling, so that many clinicians prefer medial approach in those patients, because it become very easy, because this bony structure is not going to interfere your angle of needle, and so the entry become easy freely, and it become more parallel to the probe. So many uses medial approach. See, this is one of the example of the this costoclavicular block. See, the scanning. This is axillary artery, somewhere here the axillary veins, the this is subclavius, this is pec major, and this is the area when the brachial plexus lies. And you can go from lateral to medial or the medial to lateral approach. See, this is lateral approach somewhere here, and this is medial approach through here. Okay, the thing is, there are many vessels they can come across while needling in a infraclavicular regions, and there is no exception in costoclavicular approach also. So see, when first things, this first diagram is at the level of clavicle, when you find the clavicle, and that gives a acoustic shadow over here. Just inferior to the clavicle, we will find the pec major layer, subclavius muscles, axillary artery, vein, and this is plexus, serratus anterior, and this is the standard picture of costoclavicular block. When we angle little bit downward, then this will be the pictures. See, it will be it will definitely look like the same, but the thing is the subclavius will look larger one, and just inferior, or just by tilting a few things, few angle, you will you will find that the cephalic vein is entering on the axillary vein. So this vein can be a problem for you, because when you are injecting, when you are coming through here, this can cause a puncture and many problems, so this thing you need to keep in your mind, that the cephalic vein enter over the axillary vein at this region. And one more thing is that the thoracoacromial artery that 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 appear, that derive from the axillary artery over here at this level. So the thoracoacromial artery has a 5 branches, so they may come across while doing your needling. Okay, so you need to keep two things: thoracoacromial artery branches, that those are 5 branches actually, and one more thing is cephalic vein over here. So besides axillary vein and axillary artery, these things also be a part of your flock. So try to scan in a such a way that you will find this picture. Okay, so this vein is not going to puncture, the artery is not going to puncture, and see, in this a little bit more lower angle, you will find the thoracoacromial artery over here, and this will more look like a classical infraclavicular flock rather than a costoclavicular flock. So the four vessel may come in across. So the scanning, the better scanning view is very important for a successful and the faster block. Okay, so that can reduce the complications rate. See, this is a head, this is clavicle, somewhere here, this is right side, and this is left side. See, okay, so this is head, this is right arm, somewhere here will be the left arm, this is clavicle, this is neck area, this is manti. So the probe is just below the clavicle, and I'm just going to plan a medial to lateral approach, or we can go from here is lateral to lateral approach. This is medial approach, and this time I'm going to do a medial approach. See, so again a picture which is previously already explained, either needle from medial or lateral approach. Okay, see, this is pec major muscle, this is subclavian muscle, this is pulsatile axillary anechoid artery, and this is vein, and this structure is actually cord. And see, this is at the level of 3 centimeter depth. So this is a little bit well built patient, so we are getting a more depth over here, and that gives rise to a little bit hazy picture. And uh, the Okay, so this is the this is the scanning that is utilized for the costoclavicular approach. Now see, uh, this is the block. Okay, so I'm right now planning mostly a medial approach. Let's see. This is the artery. This is artery. Somewhere here the vein, and needle is coming from medial to lateral. If you see our pec major subclavius muscles, and going just on the lateral to the artery, axillary artery, and I'm just targeting this cord, lateral, posterior, and medial cord. See, and see when I feel that I am in the sheath or very near to the cord, I started injecting the drugs, and this will require only 20 ml of local anesthetic because it is very narrow and three cords only. See, I'm on the top of the cord. See somewhere here. Okay, the drug is injected. Okay, so here the 20 ml will be good enough volume. Uh, because this is a very vascular area, we need to keep in mind for intravascular injections and the cord damage and every possibility we need to keep in mind. So again, try to be in a good plane so that the drug will pass the all the three cords over here. The axillary artery is here, and we are going very near to it somewhere here. Okay, see, this is very near to the chords and separating the chords mainly. Okay, now we will find the T4 here somewhere here. See, this chord is actually going to separate it over here, this one. Axillary artery is somewhat little bit low down. This is one more root. This is 1, 2, 3. So this require 20 ml of local anesthetic, and see, I'm very near somewhere here. My TP is somewhere here. Okay, and three distinct part, 1, 2, and somewhere here 3 is visualized over here. Okay, so this is a medial approach. See, because of prominent coracoid process or likewise, many time it is not easy to find out lateral approach uh, comfortably. So medial approach is utilized on those uh, individual patients. So I'm trying to see the needle here because it is shallow angle at the depth is little bit more. So I'm trying to see the needle tip. See somewhere over here the tip is there, and I'm separating again the uh, median and lateral chords over here. So here it is just same as supraclavicular flock. The picture looks the same, but in supraclavicular there are multiple division, and here there are only 3 chords. So let's see one more example. See, this is the approach, and okay, see, this is axillary artery. This is pec major subclavius muscle, and somewhere here the codes. I am just enter over here to reach to the code. See, somewhere over here, and this is just artery, and somewhere here will be the vein, and my needle is somewhere here. Okay, this is the injection. It is actually also containing air, so there's some haziness over here. This area is a cord area, and this is our target point, and by injecting 20 ml this will definitely block this area. So one more thing, one more hint is that you need to remove the air before injecting any drug. So that will give you that will gives you a clear picture. Okay, so the amount is 20 ml will be somewhere here is sufficient, and I'm trying to separate all three nerves, all three cords over here, 1, 2, and 3, so that the effect be satisfactory. So again, this is a medial to lateral approach. Okay, now how the doses is utilized in that is for single shot 15 to 20 ml local anesthetic is good enough volume, and if you want to go for continuous block, then the initial bolus will be 10 to 15 ml, and then you can use a 5 ml per hour is infusion rate, and initial bolus that can be used is zero point 0.2 to zero point 0.5 ropivacaine or bupivacaine, and infusion will be the 0.125 or 0.2% ropivacaine. So this is again a courtesy from Nizora. Okay, now the complication is that phrenic that can be palsy over here because it is very superficial to the supraclavicular block. Pneumothorax can be a possibility. Vascular puncture, hematoma, intraneural injections, last they can be possible over here. And at certain extent, USC gives some advantage to reduce the complications, specifically for pneumothorax and vascular puncture and intraneural injection too. Now let's see some pulse that the use always color Doppler because this area is having multiple vessels. See somewhere here you'll find the thoracoacromial artery, the branch coming from the axillary artery, and here the cephalic vein is entering toward the axillary vein. So these two extra structure will also create a problem in your pathway of the needle, besides having your patient's axillary artery and axillary vein. See, these are the 5 branches of thoracoacromial arteries: the pectoral branch and clavicular branch, acromial branch, deltoid branch, and thoracoacromial artery. So the 5 branches they actually create a problem over here, and you need to be cautious while injecting local anesthetic in these areas. Thank you.